Today's presentation on traumatic brain injury basics is brought to you by Amy Gallagher and Belinda Henderson. Traumatic brain injuries are not caused by nursing school. Traumatic brain injury is an injury to the brain caused by an external force. The teaching objectives for this seminar are the Glasgow-Coma scale, positioning, malnutrition, current equipment and technology. Traumatic brain injuries are caused primarily by falls at 28%, motor vehicle accidents at 20%, being struck by an object including sports at 19%, assault at 11%, suicide at 1%, and other means of injury at 21%. Risk factors. Who is at risk? On average, 1.4 million people suffer from a traumatic brain injury every year. Traumatic brain injury is one of the leading causes of death and injury worldwide. Men have twice the risk of women. African Americans have the highest death rate related to TBI. Children from the ages of 0 to 4, and this is due to shaken baby syndrome and abuse, and 15 to 19 years of age due to car accidents and risky behavior. Senior citizens over the age of 75 are most at risk of being hospitalized and dying from TBI. However, TBI can affect anyone at any age or stage of life. What are the risk factors? Motor vehicles or motorcycles, drug and alcohol use, sports injuries, assault, gunshot wounds, and falls. Jared Behe was shot in the head in Iraq. He survived but is still suffering from the after effects of a traumatic brain injury. The Department of Veteran Affairs estimates that Behe is one of several thousand veterans returning from Iraq and Afghanistan with some kind of mental disorder or brain injury. When looking for traumatic brain injury, the indications that you're looking for are scalp wounds, facial fractures, swelling and bruising, loss of consciousness, nasal discharge, and stiff neck. What happens with traumatic brain injury? You can receive laceration, concussion, intracerebral hematoma, epidural and subdural hematoma, diffuse axonal injury, or a DAI, acute counterproof injury, or increased cranial pressure. Traumatic brain injury includes cerebral contusions and lacerations. Lacerations involve the actual tearing of brain tissue. This young male sustained severe head laceration after being ejected from an ute which rolled at high speed in rural NSW. These are other pictures of hematomas that you can see. An epidural hematoma, a subdural hematoma. Increased intracranial pressure. Head injury is always considered to have the potential for ICP. ICP normal ranges are 0 to 15 milligrams of mercury. ICP is increased by hypercarbia leading to cerebral vasodilation, endotracheal or oral tracheal suctioning, coughing, blowing the nose forcefully, extreme neck or hip flexion and extension, head of bed less than 30 degrees, increased intra-abdominal pressure from restricted clothing or the Valsalva maneuver. The symptoms of intracranial pressure: increased intracranial pressure is severe headache, decreased LOC, Cheney-Stokes breathing, Cushing's triad reflex, restlessness, irritability, and abnormal posturing such as corticate and dysfubric or flaccidity. When you have a patient with this, you want to assess and monitor their respiratory status, if there's any changes in their level of consciousness, if there's a loss of consciousness, and what their posturing is. You also want to look at their pirouette. The Glasgow-Coma scale is the gold standard for neural functioning and should be used as soon as possible. The initial assessment should be made within 15 minutes of a patient arriving in the emergency department. Half-hourly assessments until the patient has a GCS score of 15. Further assessments every 2 hours, with the regimen being restarted if the GCS score drops below 15. There are three areas of testing: the eye-opening response, a verbal response, and motor responses. A score of 15 is standard. Scores of 3 to 8 indicate severe brain injury.
Malnutrition. TBI patients who suffered from malnutrition had 8 times the increased risk of death than well-nourished TBI patients. A study showed upon admittance, patients malnourished and at risk for malnutrition was at 41%, which had grown to 79% in 10 days, whereas 59% of the patients were well-nourished, and after 10 days it had decreased to 21%. Some reasons are suppressed vagal nerve function, which is caused by increased cranial pressure, which inhibits gastric emptying. Gastric emptying is prolonged, and disturbances to migrating motor complex indicate severe enteric dysfunction and potential intolerance of enteral feeding. Disturbances of the neural hormone corticotrophin releasing factor can inhibit GE and intestinal motility. Gut absorptive capacity is severely depressed, affecting absorption of carbohydrates, proteins, lipids, and fat. Low pressure and reduced tone in the lower esophagus sphincter increase regurgitation and aspiration. Strategies to counter malnutrition. Early administration of enteral nutrition promotes gut integrity and motility. Start within the first 24 to 48 hours post-injury if patient is hemodynamically stable. Prokinetic drugs increase intolerance to enteral nutrition, and oral Narcan has been found to increase tolerance of enteral nutrition while reducing the incidence of ventilator-associated pneumonia. Ghrelin is a newly discovered GI hormone that is effective in accelerating GE and small bowel transit. Probiotics can prevent and treat diarrhea. Administer full-strength isotonic enteral nutrition formulas to enhance tolerance. Prone positioning with the head of bed elevated 30 to 45 degrees. Detailed nutrition assessment and examination should be provided by expert nutrition nurses or dietitians, and determine goal infusion rate, frequency of flushes, and initiate rapid startup. Lastly, alleviate stress, decrease ICP, and maintain proper fluid and electrolyte balance. Equipment and technology. Cerebral microdialysis is a bedside method for measuring glucose, lactate, pyruvate, and glycerol levels in the brain. Monitoring of these cerebral metabolites can aid in the manipulation of intracranial pressure, cerebral perfusion pressure, cerebral blood flow, as well as brain tissue partial pressure. The CMA 600 can monitor up to 3 patients and 4 reagents, and the ISC Less Flex can monitor up to 8 patients with a total of 16 catheters and 5 reagents. The microdialysis catheter is attached to a syringe and placed through a bolt, burr hole, or implanted during an open craniotomy. A second catheter is placed in an undamaged area of brain tissue for comparison. In intracranial monitoring, the Camino ICP monitor is a fiber optic temperature catheter placed through a burr hole that measures brain temperature, ICP, and CTP. The Codman ICP Express is used for measuring ICP and calculating CTP. A ventriculostomy catheter provides a method for monitoring ICP while simultaneously reducing ICP through therapeutic CSF drainage. Pupillometry is a relatively new device that uses light stimulus and rapid live photography to measure maximum and minimum aperture and constriction velocity of pupils. The Hemidex system is a bedside monitoring system that monitors tissue blood flow, and circulation. The transcranial Doppler sonography is a probe with a low-frequency ultrasonic signal, and it's used on thin areas of cranium to measure velocity and direction of blood flow in the intracranial arteries. The LIPOX BP-PO2 monitoring system measures PO2 and temperature in the brain. And lastly, the ThermoGuard XP system is an intravascular multi-lumen catheter used as a cooling measure. Nursing interventions are to maintain patent airway, monitor vital signs frequently, head of bed should be at 30 degrees, stabilize the cervical spine, provide a calm and restful environment, and oxygen via a non-rebreathing.
And that is the seminar today on traumatic brain injury. Thank you.